Last talk is by Dr. Anju Chandran. She did her oculoplasty training from Shankar Netralaya, Chennai, and currently she is working in Comrade Eye Hospital, Calicut.
Thank you, Soumya. So coming to the last talk, so far we have been listening to talks which are common. I'll be dealing with a little uncommon conditions, but which also results in tearing for the patient. So not apart from nasolacrimal duct obstructions, I'm going to take you through some conditions. I'll be dealing with the disorders of the puncta and the canaliculi. So you would have come across this condition, which is the absence of puncta, also known as punctal agenesis. It can involve just a single puncta or both the puncta. Usually the patient is asymptomatic unless and until it is associated with a nasolacrimal duct obstruction. There are several other ocular abnormalities that those are associated with it, which you need to be aware of and look for as well. And it's seen in systemic conditions such as ectodermal dysplasias. Most often it's just observation, probing only if you're suspecting an associated NLD obstruction. And in cases where probing fails, then it's DCR with an monocanalicular intubation. So until I came across this entity, which was diagnosed very recently, I used to wonder why this patient has a puncta, but there's something over it which looks like a thin membrane. So it was described by Dr. Javed Ali, which is called incomplete canalization of the puncta. It is basically punctal dysgenesis with membranes, and it presents usually in the first decade. So if you look closely on the slit lamp, you'll be able to make out an avascular dimple at the site of the puncta, and through making a very small slit, you can make out a very translucent membrane, which can be present either within or externally. Management is quite simple. You just need to do a membranotomy with tapered punctum dilator, with which the patient's symptoms are relieved most often because the rest of the canaliculi is always normal. So anything in this picture that stands out? How many puncta are there? 2, yeah. So this is a condition of supernumerary puncta, which are usually the patient presents to you only when there is an associated condition like a nasolacrimal duct obstruction. So most of our OPDs are flooded with patients who complain of watering, and you will definitely not miss this, which is punctal stenosis. It's basically an acquired condition where the external opening of the canaliculus is narrowed or occluded, may or may not be associated with canalicular wall stenosis as well. So the causes are numerous, such as in aging, infectious conditions that affect the conjunctiva, eyelid, and very commonly in topical medications, you will get referrals from your glaucoma counterparts, and patients who are on systemic medications, especially for oncology purposes. And there are several other conditions like malposition, trauma, and so on. So there are grades that have been described, which are for academic purposes. Just have put them up for you to see and know. Treatment options are only if the patient is symptomatic. And earlier it was described that you could do a 1-snip, or 2-snip, or 3-snip punctoplasty. But slowly the trend has shifted towards punctum dilatation with monocanalicular intubation. This is to preserve the integrity of the puncta so that the physiology is not tampered with. There have been uses of perforated punctal plugs, which there are chances of the plugs being lost and the outcome not being very good. So recently a colleague asked me that I saw this in a patient, what should I do about it, should I observe? So I believe that any growth that is recent has to be excised and be sent for a biopsy, because it can be either a benign lesion such as a melanotic nevus, a squamous papilloma, epidermoid cyst, or hydrocystoma, and you may not be, you shouldn't be surprised if you even get malignant lesions such as a sebaceous gland carcinoma, a squamous cell carcinoma, and rarely malignant melanoma as well. So this was a 75-year-old gentleman. So when you see a patient like this in the OPD, the first thing to do is you need to probe and see if the canaliculi is intact, and you can also follow it up with syringing to see if it is free. So once that is assured, then the next step is to excise it, and when you excise as well, make sure that you have a probe in place so that you excise it around at the base. And then follow it up with a monocanalicular intubation. My favorite is the mini monoca, which is trimmed and inserted into the canaliculus. Leave it for about 4 weeks, and the patient will come back to you saying that the watering has reduced. and the puncta heals almost always very neatly. So quickly through the disorders of the canaliculi, this was one gentleman who kept complaining of discharge and watering over a year. He went to multiple doctors. He said that he was given topical antibiotics, but no relief of symptoms. So if you look closely at the picture, the left upper puncta and the associated region, it is inflamed, and he had classically what is called the pouting puncta. On manual expression, you get concretions, so which is a telltale sign of the condition, canaliculitis. So I've covered the presenting signs. The causative organisms are usually actinomycetes, streptococci, and staphylococci. So because of the presence of concretions, most often the medications do not reach the canaliculi where the pathology lies. So it is important to do a punctal dilatation and curate out all the concretions. It is divided as to, you can do a punctal sparing canaliculotomy, or you can do a punctoplasty with curettage, but I prefer a punctum sparing one. This is followed by warm compresses and antibiotics. Just quickly at this very recent condition that was described, which is called idiopathic canalicular inflammatory disorder. There are a series of stages that the patient goes through, which is initial progressive edema, then vascularization, then pouting of the vascularized mucosa, membrane formation, and eventually progressive cicatrization. If you look at the criteria, one thing is negative microbiology workup and negative systemic involvement. There is a relentless disease progression and the disease response to steroids. So the treatment would be a punctum dilatation with a mini monoca intubation at least for 4 weeks. You start the patient on tapering topical steroids and follow it up with topical cyclosporin for at least a minimum of 3 months to get the adequate response. Just a quick mention about canalicular injury, which is all you should look for this, especially in lid tears which are medial to the puncta, and it has to be repaired properly with a stent in place for at least 3 weeks again, so that you can restore both anatomical as well as functional integrity for the patient. Canalicular blocks, you usually get this in your OPD. You will have regurgitation of clear fluid from the same puncta. This need not be addressed unless the patient has an associated NLD obstruction. Common canalicular block, I will finish with this slide. So what you would find is regurgitation of clear fluid on syringing, which need not be an NLD obstruction. You should always do a probing to confirm whether it is an NLD obstruction or a common canalicular block. In this case, you will get what is called a soft stop. Some other rare conditions, which are canalicalops and canalicular wall aplasia. So I cannot end a topic or IC on dacryology without mentioning this great man, Dr. Mohammed Javed Ali, who has contributed so much to dacryology, and his textbooks are up here for you to read if you have a special interest in dacryology. Thank you.